Good afternoon, everybody. My name is Ron Ackermann. I direct the Institute for Public Health and Medicine, and I want to welcome you again to another week of our IPHAM webinar series. Today's series features a special mini-series that we have called Exploration of Careers in Public Health. This series features interviews with local public health leaders about how they have navigated their careers in public health. If you haven't joined us during one of these sessions before, this is a dynamic format, and it will be moderated by Dr. Peter Orris. I will introduce Peter and our speaker in a moment. I want to welcome you to post questions that you have or that arise during the presentation at any point. Please be sure to use the Q&A button at the bottom of your Zoom menu, not the chat function. We won't be monitoring chat, we'll be monitoring the Q&A. So use the Q&A at any point, and we will address those questions at any point, and possibly more towards the end of the conversation today. So with that, I'd like to introduce first Dr. Orris, who is Chief of Occupational and Environmental Medicine at U of I Health. He has more than 4 decades of experience practicing internal and occupational environmental medicine at Cook County Hospital and other institutions in the Chicago area. He's also a faculty member at the Department of Preventive Medicine at Northwestern University, Feinberg School of Medicine. At Northwestern, Dr. Orris has taught or co-directed several courses, including a popular course that brought local public health leaders to the classroom to talk about their careers. And this is the format that motivated our webinar series that you will join today. Our guest today is Dr. David Ansell, who is Senior Vice President for Community Health Equity at Rush University Medical Center. As Rush's first leader of community health equity, Dr. Ansell leads Rush's strategy to be a catalyst for community health and economic vitality on Chicago's West Side. And we look forward to hearing about this more today. So with that, please join me in welcoming Dr. Orris and Dr. Ansell. Peter?
Thank you, Ron. And thank you, David, for joining us for this discussion. And I apologize if I come in and go out. I'm using a laptop. I'm quite technologically challenged today. Having said that, it's really, you will get more support this year than you got 3 or 4 years ago, because you don't have to do it all on your own, David. And we will be asking you questions as we go. David Ansell is well known, I'm sure, to most of you who are in the conference today. And he's a little easier to introduce than most others, because of his several books and popularity of these books, and the first book being his experience in training at County Hospital, having come here from the East Coast. And that's where I'm going to begin with the discussions as to, as a medical student, and one in general interested in the social issues of medicine, why County Hospital at that time, and why did you think that was an area that would train you in what you wanted to learn about medicine, since I'm sure your advisors at your medical school advised you to go anywhere else but county. So let's begin back there.
Well, you know, the road traveled is always clearer when you look behind you. And first, thanks, you know, Ron and Peter for this opportunity, because I think it's great for students to think about what a career could look like. So I was in medical school in upstate New York, and was profoundly painful experience for me and my friends, because I had this notion that being a doctor had, you know, had universal value. And when I walked into medical school that first day, I understood that it was the system that was broken. And it was very clear through medical school that we were living in a broken system. Actually, look at COVID. The connection in this country, and this is an evolved thinking on my part, between an economic system named capitalism and healthcare as a commodity was profoundly disturbing to me in medical school. And it led me, to have moments of despair, really, when I thought I was going to quit. And I didn't know what public health was. But a group of us got together and began to study the US healthcare system and American history, and actually world history. And we understood that first year of medical school, that's going back now 45 years, understood this connection between US history, and perhaps including the legacy of slavery and imperialism, and how healthcare developed in this country on the foundations of white supremacism. And it led us to study the healthcare system. And in that study, we learned about some organizations that had been around prior to us going to medical school, something called the Student Health Organization. I think that was the name of it, Peter. You were in it, you were a leader in it, SHO, and the Medical Committee for Human Rights, led by a guy, many people, but one of the leaders of it was someone named Quentin Young. And people always see Martin Luther King's famous quote about of all the injustices, I won't never get it right, healthcare is the most, injustice in healthcare is the most inhumane, was spoken at a Medical Committee for Human Rights meeting in Chicago. So when it came time to go on, medical school for me was medical school plus, study on and activism. And when it came to decide where to go, we decided as a group that we wanted to go to a place that was at the intersection of society and health, we wanted to put ourselves right at the center of everything that was right and wrong about healthcare and health in America. And we looked around the country, and that was going to be one of the public hospitals in the country. And we picked Cook County Hospital. And then to make sure that we all got here, we only matched one place on our match list, if people understand how the residency match works. We just put county on our match list, so we got transported here. Quentin Young, that person I talked to you about, was chair of medicine at Cook County, and Peter Orris was a third-year resident when I got there, one of the leaders in the Student Health Organization, very active in the civil rights movement. So we just knew that we had to land there without having any idea of what would happen next. And it was honestly, if you look back on decisions you make in your life, absolutely, maybe other than marriage, the most important and significant decision in my life, because I'm a white kid from upstate New York. My parents were immigrants to this country. We didn't know from America in my family. You just land in a country and you're trying to figure out. But it was at that moment in time I began to discover, the path that I've been on ever since.
And you used the term commodity in conflict with your goals and your concept of medical care. Tell us what that means. Why?
Yes, it's a great question, because during that first year of medical school, first thing that happened to me when I walked into medical school is they handed me a Eli Lilly stethoscope, which I handed back. And I read this little pamphlet, which I still have a copy of, called Billions for Band-Aids. you might remember that, Peter, as being talked about the healthcare system and the connection with capitalism and for-profit medicine. And I hope we get into this a little bit more, because our current state is really the problem that we've seen during COVID is exactly the problem when you organize healthcare, health systems around profit making, where elective surgery makes you profit, but not taking care of COVID people. But realizing walking into medical school, this wasn't as I thought it would be, required me to do deep study. And my personal conflict that I had about whether I should stay in medicine was resolved when I met this group of people who we began to study these things. We all knew what we wanted to be, doctors, but the why of it became very clear, that health was a human right. And when you say health is a human right, and that became sort of my guiding purpose. And if I describe myself as I'm a doctor, I'm a hospital administrator, I'm a social epidemiologist, I teach, all of these other things. But if you ask what my real why, true purpose is human rights activism. So I from that first year in medical school, I began to identify myself not as much as a doctor, but as a human rights activist. And so that then guides what you do next, or where you go and what you do. So that was it. And to say that healthcare is a human right, that means it's an entitlement. Just as speech is an entitlement, or the right to housing or clean water or school is entitlement. And when you say it's an entitlement, that means everybody should have it by dint of their very birth. And that puts you at, really needing to oppose a system that has made profit at the center of it in any which way you can. So that was my underlying thinking.
So you arrived at county, this is 78, as I recall?
Yes.
Yeah, and as a hotbed of social activism, as teeming humanity, as more demands on you as a physician in training than you could fulfill, and no isolated, separated time for academic pursuits. Yet you accomplished in short order something many physicians or many trainees aspired to for many years and do not have it. In other words, an article in the New England Journal of Medicine. What was that all about? How did you marry the academic with the activism and the social service?
Well, that's a great question. First of all, is our colleague Gordy Schiff, now at Harvard, but many years at County, used to say, we're so far behind, we're ahead. And by that, I meant, attending physicians. It was a resident and student-run, nurse-run hospital with nary an attending physician in those days, or even an administrator, thank goodness. But we were disciplined in the sense that we taught each other. And in order, when you find yourself in a situation like County, first of all, the people that we were with were just one spectacular human being after another. And when you think back on the concentration of that, both energy, intellect, passion, social justice, we could not agree on lunch. We were always in some form of conflict, but there was really a hotbed of ideas and such. What happened was the understanding, and what I learned there was social medicine. What I learned at Cook County was that activism, so advocacy is the work we do for our patients within the walls of an institution, trying to get our patients the best care they can get, or even their families and community members. But activism is actually practicing medicine with your feet. And so we were both advocates and activists. But I have a formula for change that looking back, that I think's really important to say, how does change actually occur in our world? Well, it's a narrative plus data plus action equals change. And you need all three of those things. So the narrative at the time was people were being transferred to Cook County Hospital because they had no insurance. Well, that's what county hospitals were for. In fact, that was the norm of county hospitals, probably from the beginning of time of county hospitals. In fact, in 1979, when I was still finishing my first year, the BBC came and made a documentary of county, and it's called I Call It Murder. It's available on YouTube. I suggest you watch it. And it was to tell the Brits about healthcare in America by telling the story of what was going on at county. And a friend of Peter and mine, a fantastic physician, national leader, Linda Ray Murray, was the head of the House Staff Union. And she was asked by the BBC if they were watching patients being just brought into county from other hospitals with all kinds of problems. And they asked Linda, how do you describe what's going on here? And she says, I call it murder. And it became the name of this documentary about Cook County Hospital. So what happened in the 1980s was the following in this country, and it started on the west and south sides of Chicago: deindustrialization. So I want to tell you what happened. So you've heard of redlining, you've heard of concentrated segregation, but when people were invited to come to Chicago from the south, they came because there are plentiful jobs in factories. These were Zenith and Motorola and Sears and many great places, but you had redlining, white flight, and then decapitalization. Businesses that had been in these communities for years and years and years, rather than modernize their facilities, moved and left. And in their wake, they left communities of uninsured people, because people in those days had insurance. Now, there was racism in the distribution of healthcare, but it wasn't all economic. But now you had a large number of uninsured. And what we saw at county in the 1980s was the rise in patient dumping. It went from 100 a day, 100 a month, which was our average, 100 patients transferred every month from other hospitals simply because they had no insurance, to 600 a month. Well, we said, gosh, we could go and have a demonstration about this, but we didn't think anyone would listen to us. So a group of us decided to do a study. And we took 3 weeks. We said, let's do 500 patients. It was 3 weeks to get 500 patients. 500 consecutive patients transferred to a hospital. At that point in time, I had never thought of doing academics or doing research, but we knew that unless we could credibly put this down on paper, put the numbers together and see where the bodies lay, to paraphrase Virchow, the mid-19th century pathologist who was the founder of social medicine, we realized we had to do a study. And so that's what we did. 3 weeks, we collected the data on the impact on patient transfers, dumping on health outcomes. And of course, there were a lot of deleterious outcomes. I'd like to tell you one patient, because it really made me think about what was really happening. So we not only looked at the data, we kept a list of the cases. So here was one, a woman, 10 centimeters dilated in the terminal phases of labor, foot in the vagina, transferred to Cook County, and the reason was no insurance, which it was 90% of the time a patient got transferred to county for no insurance. Of course, we all knew this, but many years later, I began to think, Peter and I would be in the emergency room, the phone would ring, and we'd get a patient phone call, and we'd always accept the patient. Then I thought about the residents on the other side. They're just being told to follow the rules. And our rules at this hospital are, if you get an uninsured patient, transfer to county. Can you imagine transferring a patient 10 centimeters dilated, oh, breech delivery, foot in the vagina, because your administrator told you to do it, but that's exactly what happened. So we submitted it to the only medical journal we knew, and it got accepted. And that paper actually helped change national law. So the Emergency Medical Treatment and Labor Act was passed partly in response to this and other work that was done around the country. It made me realize at that point in time, the point of academics is to change the world. And how do you leverage not just the story, like I told you, the story of the woman, that's shocking, but the data that confirms it to take action and get public policy change. And so my academic career is aimed at social change.
So we have an interesting question, which I'll give to you, but in the process of going there, would you give us a little advertisement for your first book, County, and why you wrote it and why you think it may be of use to the students today, even though it's some years later? And then I'll get to this question. Do that one first.
All right. Well, what happened to me is I spent 17 years at Cook County. First of all, never looked back. The most amazing decision of a lifetime going there. And then I got recruited to go to Mount Sinai. And it was the stupidest thing in the world to do. Because county, I've been at 17 years at county. By the time you get 20 years, you're 2/3 your way into a pension. That's a pretty darn good pension. You know, it's something you don't think about when you're young, but you think about when you're older, how you're going to retire. And I got recruited to Sinai, and I went there, and it was in the middle of Lawndale. It was like county without a safety net. And I said, this would be really interesting. What's different about Sinai, it was right in the middle of the epicenter of the community that is the poster child for redlining in the United States. You want to pick a neighborhood that you want to be, and I said, it's in the neighborhood. County wasn't really in the neighborhood. The patients came from the neighborhood, but it put me in the neighborhood. I gave up my pension, guaranteeing myself a long and happy life of work. But I ended up at Sinai, and I was there 10 years. And at Sinai, I looked out on my window, and I could see the Sears Tower. And then I looked down the window this way, I could see the Tower of Western Electric. This place employed like 60,000 people. And then I understood the interconnection for the first time in a deeper way, the interconnection between place, public policy, acts of affliction like deindustrialization, decapitalization, acts of affliction, racism, and mortality. And at Sinai, I recruited a very good friend of mine in to lead the Sinai Urban Health Institute, which is still there today, a terrific organization, with the idea we were not going to look at why people are dying, but what were the afflictions that are going on in neighborhoods, and began to do work on place-based causes of sickness and death. And it was some of the early work in the country that went on in the most unusual place. But I left it and wanted to go back to county, and I didn't have a job at county. And Rush was looking for their inaugural chief medical officer, and a guy I knew was the chair of medicine. He said, you should apply for it. And I applied for it and got it. And the reason I came, it was right across the street from county. And I figured, well, at least I'll be close to county. But when I got to Rush, I was shocked. I really was shocked, because after medical school, I said, I'm never going back to an academic medical center ever again. And county was like, you know, being at home, and Sinai the same way, you know, and then I got to Rush, which is a terrific place. My patients got just amazing care, but I began to think about Ogden Avenue, this one street in Chicago, where I've spent now 40+ years practicing medicine with the same patients pretty much. And we've done a litmus test on everything that's right and wrong. How could you have a hospital on one corner for the poor, where we were grasping for resources, you know, just out of reach, and another hospital on the opposite corner that was meant for the other people, those who had? And what I found when I got to Rush is people at Rush had no idea what went on at County or what went on Lawndale. And so I wrote County. I wrote the book because people, I wanted to make visible what was invisible to most good-minded people that I met. They had no idea that literally outside the door was a completely different world. The second observation was, I thought it was enough for people like Peter and me and all the other people I know to go to places like Sinai, Cook County and Sinai Community Health Centers. I thought that that would be enough, but I realized how exploitative the system was, and the exploitation that went on that made it okay that if you had a certain card on Harrison Street, you turn right, you know, and if you had another card or no card on Harrison, you turn left. And what an awful system. And so I wrote County in a way to tell the story of what it was like to go there, but also to see that the system itself needs to be changed.
So actually, I'm going to then get to a couple of these questions because you answered my next question, and that is, we had interviewed in this series Nosy Exike and Linda Murray, and these were two brilliant physicians who remained in the public sector doing public health at the county in the public clinical sector, and then both moving into the public health more traditionally, non-clinical sector. So I was going to ask you about how did you see doing public health at Sinai and then at Rush? We'll come back to Rush. But in other words, we want to tease out the differences between these various careers. But let me give you these two questions first. Regarding anti-racism in medicine, what are some ways you see medical education changing that makes you hopeful? And what areas do medical education still need to change? And a second companion question, what solutions are there to the lack of African-American and other minority physicians? Do we need to change criteria for admissions to medical school? And perhaps you talk some about your initiative and maybe mentioning Fitzhugh Mullen on the way as he passed in the last year. So let me leave that to you. Expand as you'd like.
Yeah, well, let's start. Fitzhugh Mullen, who died, I think, last year, terrific. You probably knew him very well, and I knew him. Wrote a book that I read in medical school, White Coats, Clenched Fist, which really made me understand that we could be, as physicians and healthcare leaders, workers, actually be activists. And that was not only a calling, it was a necessity. It took me a long time, even though all my years in county and my 27 years, almost 30 years working in safety net and always doing public health. I have a public health degree. I'm an epidemiologist. So my work has sort of evolved into understanding, putting one rate over another rate and calling that difference in inequity has been the basis for my work. But it was only, one could go to a place like County or Sinai and see the toxic effects of poverty, the affliction of poverty, the oppression of poverty on the body and the soul. By the way, you should read an Atlantic article on Lawndale called The Case for Reparations, but by Ta-Nehisi Coates in the Atlantic. It's really important to understand how public policy decisions and structural racism itself has led to the destruction of communities like Lawndale. That's a great article and a really good and important read. so I could see the toxic effects of poverty on the bodies, on the spirits, on the souls of my patients. The diseases that I saw and still see are somewhat beyond traditional medical treatment. I realized that medical treatment was really a problematic approach to these deeply embedded political, economic, and social problems in communities. But it took me probably until 10 years ago when I began to understand that it was up to white people in leadership and white people not in leadership to name racism as a root cause. Particularly in this country, as the root cause of health gaps and life expectancy gaps. So that became very, very important personally for me to begin to name it. And what's quite remarkable about this, now it kind of rolls off many of our tongues, which is great, but there are very few white leaders and white doctors who actually speak to racism as a root cause of poor health. And that is critically important to do. And then we have to teach within our medical schools curriculum on how racism kills. The problem is if you're a regular, if you're a physician who grew up in concentrated white affluence, or you've been assigned to whiteness, back in Europe, I'm Jewish. The Jewish people were assigned to the bottom of the caste system, but in this country, we've been assigned to being white. So we have all the privileges that coming with whiteness. It became really important for me as part of my own leadership to speak about racism and then think about how do we teach it. The problem is if you've grown up in concentrated affluence and whiteness, and then you're now a doctor and you're good-minded and such, you may not have the tools to actually teach. So we've done a survey of our medical school and actually our faculty at Rush University, and most of our faculty do not feel comfortable to teach concepts like racism and other forms of exploitation is causes of ill health. So we have a lot of work cut out for us to actually get faculty ready. Now, to the second question, why don't we have? Because we do not disproportionately recruit in Black and brown folks into medicine. And we've got to, it's a scandal that we're as bad off as we are, and we've got to do more work to do this. So what I will tell you, the reasons why this is true is because white supremacism as an ideology, along with sort of these ideas around we can have a capitalist healthcare system and people can get good health outcomes, is at the root cause of many things that are wrong in many of our institutions. And that's why people like me, see, I could have these ideas and be invited into leadership at Rush because I was familiar. I had a familiarity. I think my white maleness has allowed me into rooms. But I do think over time I've learned to speak about it more because I think it's so critical to the health of our people in our country. But we have a lot more work to do because and every step of the way, young Black people, particularly young Black men, are shunted, off the educational path and into the incarceration and the marginalization path that leads so few at the top. And then there are a lot of reasons why people get X'd out even when they get to the top. There's a lot more for us to do.
How does a young person who is struggling to be competent in the increasingly complex medicine of today with the complex technologies and treatments and understandings, how can someone like that who has a perception of these causation of disease but is involved in the treatment of disease participate in the kinds of issues and impact on those issues that you are outlining? How do you compartmentalize a clinical career with public health issues?
That's a great question. I mean, I think it's a terrific question. First of all, I had no idea what I was doing. And had I, I was like, oh, I should get a public health, I should get an epidemiology degree, because I wanted to understand I got involved with breast cancer, disparity, we called it in those days, inequity in these days, difference in black, white outcomes in breast cancer. And I knew I needed to evaluate the work, and that led me into public health. But I tell you, my interest from all times was in what you might call community health, public health. The difference between probably what I do and public health is sort of really maybe more explicit in my work, is naming both racism and capitalism, sort of an unregulated economic system, as root causes of poor health. That you hardly ever get in medicine. You hardly ever get in medicine training, and you hardly ever get it in public health training. To maybe now more these days, we're becoming more facile with it. So I went into medicine not knowing that public health existed. So I became a doctor, and I became a primary care doctor because I knew I wanted to be really at that interface. Had I known I didn't learn about occupational medicine until I got to county, and I realized there was a program there, or I might have gone into occupational medicine. But I loved primary care, and I loved the practice. So remember I told you this thing, the narrative plus data plus action equals change. The narrative piece of this is, from a doctor's perspective, sort of I get from sort of talking to my patients and understanding how the N of one of their condition can speak to things that are going on in the community. And so I don't look at it so much as compartmentalizing as toggling between two different ways of viewing the world. Yes, we have to heal the sick, we have to treat those who are infirm, we have to help those people who are in need, and practice in the practice of medicine, which I never gave up. Most chief medical officers, or actually just about everyone I know in the country who had a role like me, stopped practicing. But practice was fueled actually my curiosity about what was happening in the community. And then what I did, actually, I don't think you have to go look for the problems. The problems will walk into your office or walk into your place, and then you pursue the problem. Peter and I have one this week. I mean, a woman reaches out to me because she read my second book, The Death Gap, and she's in Kalamazoo. And she lives in the North Kalamazoo, which is a black neighborhood, and it's next to a paper plant. And everyone she knows has lung problems. And she says, can you help to see if there's something related to where I live? And my community, by the way, she says environmental racism, because it's all black people in this stuff. And, I reach out to Peter and this, something like that. And suddenly, I don't know if anything will come of it. But the point is, you don't have to go looking in a society like ours. You don't have to go looking for these problems. They're walking into your office. People are reaching out to you. And that's how I've done my work, is really somewhat iterative around that. I got involved with breast cancer work in Chicago around black-white gaps at a time when everyone said it was biological and we said it was structural racism, and then began to set out to how to prove the case and then how to improve it. And we did all of those things, usually in groups with others, at a time when I'm practicing, at a time when I was even chief medical officer doing other things. I've always set aside the time to do community health and public health work around inequities. And the reason why I've done that is because that first year in medical school, I discovered health is a human right, and I was going to be a human rights activist. So no matter where I've been, this has always been my work. And so it was never a matter of, it wasn't so much a matter of compartmentalization as I sort of look at it as part of this holistic piece of work that I'm required to do.
So let's take advantage of your description, perhaps, of yourself as a a spy or an irritation in the C-suite. I mean, you were not just a clinician, you were chairman of medicine and chief medical officer of the fastest rising hospital mega complex that has elbowed its way in between the University of Chicago and Northwestern in Chicago. So having said that, you're sitting there in the C-suite, and here's a plaintive question from somebody on the other end of the totem pole, if you will, here in Chicago, who says, how can community members and potential medical students put pressure on those white leaders, chairmen, and hospital administrators to both educate themselves and implement anti-racism policies in the hospital? How can medical students put pressure on these hospital administrators without potential backlash from those administrators?
All right.
One for you.
Peter, you may have to help me with this one. So here's a little bit. It's a great question, and a lot of people, I've heard it many times. And Peter's the same way as me. So I have to say, in the same way as we probably share in our cohort at county and others around the country feel the same thing. You know, number one is I am always going to speak on behalf of human rights. I'm never going to censor myself on behalf of human rights, never. And it's a decision I made very early in life. I had to learn to be able to speak. When I met Peter, when I was an intern, I didn't know how to speak. I had to learn how to get in front of a group and articulate it and do it in a way that, you know, at least I got out what I wanted to say, and maybe it could be heard by others or not. But the obligation to speak is independent of whether that speech can be received. So that's number one. Number two, I have this sort of thing about looking in the mirror first and asking myself, so I got myself, when I got to Rush, now I'm like totally sort of well-defined by then. I'm in my 50s, I'm at Rush, and I had a CEO I hardly knew, a guy named Larry Goodman, terrific human being, by the way. And I realized that part of my job was to get him to hear me, what I was saying. And then for me to allow it to go through his brain and come out processed the way he saw it. So I always say, when I come up against a stop, I always ask myself, what more can I do in this moment to get the results that I want to get? So I would come to Larry and say, Larry, we just published this paper, and there's this big gap between in Black and white women in breast cancer in Chicago, a mortality gap. And we want to start a task force on this, because we think it's actually structural racism and not biology about this. What do you think about doing that here? And so he would say yes. Well, yeah, just go do it. And then we go do it. And then he'd hear from his oncologist that David Ansell is saying that the reason why there's Black and white gaps in breast cancer in Chicago is racism and it's biology. And then he would come to me with what the oncologists are telling him. And then I would have the discussions with him. Now, a lot of times, and I did the same thing about a group of demonstrators come to Rush one Christmas Eve demanding transplants for the undocumented. And so I'm the chief medical officer. It's Christmas Eve, it's a Saturday. And what do? I drive down to the hospital. They're demonstrating in front of our new tower. Our giant security guard, Orris, he's 7 feet tall, 4 feet wide, is trying to keep them from coming on. They got baby Jesus. They've got guitars. What do? Health is a human right. I invite him in. And I start to enter in a dialogue about transplantation. And I know the motto is narrative plus data plus action equals change. So I lever that with the senior leadership to begin to talk about there's an ethical and moral imperative to our work here. And ultimately, what would happen is what I would say would influence how people would begin to think about problems. I would say, Larry, it's this transplant thing. I don't know if you know about this, but when people sign up on their driver's license, give away an organ, it's because it'll be altruistically given to the next person who deserves it. Did you know that? And it's not about money. It should be based on need. And so, by the way, do you know that 30% of the organs come from Black and brown people who are uninsured? And just giving the data around it would allow, at least in my institution at Rush, people to begin to think differently about this. This thinking during COVID, so COVID hits, I go to our CEO now, a new guy, who was actually my deputy CMO, and our philosophy was our job is to take care of sick patients and not do wallet biopsies. COVID hits, and he and I have a conversation, and I call up all the safety net hospitals in Chicago and say, send us your sickest patients. And we took care of those sickest patients and transfer. But that's how it translates. See, there have to be more people who are willing to speak about human rights, around social justice, across all our organizations. And you just have to not worry about backlash. You have to worry when you get a backlash, when you're shoved back, look in the mirror and say, what more can I do? So if you want to take on anti-racism, form a committee. Demand to meet with your senior leadership and keep pushing these ideas ahead. I mean, this is, Peter, that's how we did it, right? I mean, we just have to be somewhat, you have to be persistent, you have to be relentless, and you have to understand that as a doctor, you're at the top, you're part of the 1%, no matter what. But you can't be deterred by fear of retribution.
And there's another very interesting question about a similar topic and concern about somebody young with a master's in public health as their final degree, and therefore with some less job security than physicians, and wondering where he or she might get employed, where she can or he can combine the social mission with making a living and working in the field, when, let's say, an MPH in epidemiology is their degree. What kind of positions are available?
Oh gosh, there's a lot. I gotta say, we're nowhere near winning the problem of health as a human right in this country. In many ways, you could say, it's particularly in the last 4 years, but over the past many years, we've lost, in many ways, the gap between the link between wealth and health. It couldn't be greater than we have right now. On the other hand, particularly for Generation Xers and millennials, the narrative around this of racism, the narrative of the exploitative nature of capitalism itself, and how it devalues our system, the idea of perceived racism and the biological impact of racism and other forms of exploitation on biological changes in the body are all being studied widely across the United States. And people who are going into social epidemiology, there are jobs everywhere. We have jobs at Rush, at the public health schools. So there are definitely places to do this work. And what I would say is, when you're pursuing this work, I mean, to me, I've had I've had this amazing privilege of being able to do this work and experience joy around doing the work. I mean, I would say Peter's the same way. We could retire, but there's not one part of us that wants to retire, because actually doing justice work brings joy. And even though we've witnessed such really bad things happen, we're so convinced that we're right and this is the right path that we're, you know, when you pursue a career in this as an epidemiologist, you know, you're going to find a lot of joy and a lot of opportunity, I think, right now in this period of time, because there's a lot of work going on this. But I got to say is, you know, studying the problem, you got 1 point for naming the problem and 100 points for fixing it. So where the real place to land yourself is who's trying to make it better, and show me interventions that really can make a difference, because then you really will feel like you're in that action mode of my formula. The data doesn't change anything. Actually, just naming racism, no one dies and no one gets better simply by naming it. The data itself is getting to action. So if you really are interested in being on the sharp end of this thing, get into interventions, you know, and I'm happy to, if you want to email me offline or have a conversation, David_Ansell@rush.edu. I'm happy to have a conversation with you and even put you into contact with people who are actually doing this kind of interventional epidemiologic related research.
Well, that's almost a good ending as you're communicating this, but let me steal another couple of minutes from you and tell us, now that we're breathing a little easier this week than last week, although COVID may be impacting on that as well, and assuming there's no coup d'etat in the next 7 weeks, what do you see as the most important thing for a physician with social activism and consciousness to be doing at this point?
Well, people talk about social determinants of health. I don't like that word. I think patients have social needs. Community have many structural determinants. There are obviously economic determinants of health, whether you're black, white, or others. If poverty is a thief, it will steal health away from you no matter where you live in the world. But there are political determinants of health. And a lot of people go into these fields as sort of neutral. You know, I'm not going to be political. But I gotta say is public policy makes a huge difference on who lives and who dies. And it's the thing I began to learn that first year in medical school, that if you go into public health, you must be political. And what do I mean by that? It means so the data from Raj Chetty, whose work you should review, who's a very famous economist who someday will win the Nobel Prize for economics, mark my words, has done a lot of work in the United States on income, race, and mortality. Look up his stuff. He's got some great YouTubes. What he has demonstrated incontrovertibly, that where you live when you're poor dictates when you die. And that's all related, many things related to public policy. And so one of the things is going to be, so universal health care, but even more important than that is Medicare for all, single payer healthcare. Why do I say that? There's many different systems. Why not just expand Obamacare? Because of what I mentioned before, that capitalism and racism have gone hand in hand. And therefore, our healthcare system is racialized, and those health centers and hospitals that disproportionately take care of Black and brown people are then, because of our the economic stratification that capitalism has done for our healthcare system, everyone has a different card, and hospitals and clinics that serve Black and brown neighborhoods are undercapitalized, can't afford. I've worked in the same places. I'm a much better doctor at Rush because it's got all of these resources, you know, that are around me than when I was at County and Sinai. Same doctor, same patients. And so a single payer healthcare system will at least give everybody the same card and the same ability to move potentially across the system. Doesn't solve all of our problems. Doesn't get rid of the fact that, you know, wealth inequality drives health, and educational inequality drives health much more than healthcare. But I would say that that would be one thing. So we must be political. Public policy makes a difference. How we regulate capitalism, makes a huge difference in who lives and who dies. And when you go into these professions, you don't think about it in that way. But I do think that that's got to be, if you talk about compartmentalizing yourself, one of your compartments has to be in the political domain. It makes a difference. Public policy makes a difference. Laws make a difference. And we have to be active in those fronts as well as the social fronts.
Well, again, that's a good sum up. I have another couple of great questions from the students, but we're running out of time here. One takes you back to Jewish ethics, etc. And the other is a continuation of the importance of significant numbers of African American and other minority professionals at all stages within healthcare. But let us just say thank you very much for this hour, or almost hour anyway. And really appreciate your participation in this again. Did you want to say anything about Beyond Flexner for a moment, as maybe relevant to the students here? And
I just want to, maybe I'll just end on this note. In the mid 1800s, there were people began to understand more clearly the relationship between social conditions and health. It probably wasn't the first time in history, but it was the time in modern history. The Enlightenment had occurred, and a guy named, I mentioned before, Rudolf Virchow, one of the most famous doctors in history of medicine for all kinds of reasons, went to look at an outbreak of typhus in the Silesia region of Germany, and came back and said something like the reason for typhus outbreak and the death rate was the lack of democracy in Silesia. Actually, it was a potato famine like that in Ireland, and people were starving, and then they got typhus. And Fred Engels, who studied workers, Frederick Engels, in Great Britain, and looked at worker mortality and called it a form of murder. Back to Linda Murray, I call it murder. The fact is that how we name and talk about social conditions as causes, acts of affliction, oppression, is cause of death is critically important to medicine. And that field of social medicine has been cut off, and public health grew up somewhat separately, and we have to bring them back together. And we're only going to bring them back together when we see that our practices have to include these sorts of practices, both activism, but actually study, community health, and other things like that. And it's not just, I'm going to do a career in public health, or I'm going to be a career in medicine. They all have to come together, because the only way we're going to actually make improvements. So I want to end on that note. That's what I discovered my first year in medical school. Now, all these years later, I'm still practicing. And there are many, many fantastic things going on in Chicago right now. A racial equity rapid response team, partnering providers with the community, with the city around COVID and many other things. So if people want to email me with questions, I'm happy to answer them. But thank you for having me, Dr. Ackermann, as well. It's a pleasure to be here.
Thank you, David. And this series has concentrated on Chicago and Illinois for the first three. And because of using this virtual arena, we will branch out internationally as well, beginning in January. But we really appreciate your participation and the group's participation. Thank you. Ron, was there more you wanted to say about the next several sessions?
No, that was great. Thank you, Peter. And thank you again, David. That was absolutely wonderful. Really appreciate having you today.
Yeah. And hope the students just know you can all do this work. There's nothing in front of you except your own reluctance. And please reach out if you have any questions. Thank you.
Thanks a lot. Bye, everyone.